Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Welcome back, Jeff.
Nice to see you. How was your summer?
Well, it's almost over, which is crazy to think. We're approaching September. Crazy how time flies.
I know, and it feels like it's been a weird summer. Like it feels like it's been so short, and it's Labor Day this weekend. It's crazy.
Well, everything's changing so rapidly, and I actually think this podcast is very timely. You know, we're heading back to school. There's a lot of mental health concerns in general now, but particularly in youth. And today we're diving into the CANMAT 2024 guidelines for major depressive disorder. And I'm here with, you're a bigwig. You're part of the development. Totally. Completely.
It was fun. These guidelines, I mean, I do a lot of guidelines, and these were very fun to do. Like they're really nice guidelines.
Okay. So let's just set the stage. What's up with major depression these days?
I mean, first a call out. I mean, it was a large committee. I was the only family doc, but a call out to the chairs of the committee, Ray Lamb and Sid Kennedy. They did a lot of work. I mean, Christine, we talk about all the time. Depression is one of the most big five that we see in primary care. Depending on what you read, 11 to 15% of the population will develop a major depressive disorder in their lifetime. And we're not talking about the blues or being in a funk because you lost your job or it's a pandemic or you have a divorce. We're talking about true DSM-5 diagnosed depression. It's really common, and we're the ones they come to, right? So, I mean, the problem is this. People come in and still in 2025, they're saying, oh, can I see a psychiatrist? Like before even saying what the problem is, they're saying, can I see a psychiatrist? And my answer is typically no, but why do you need to see a psychiatrist? Because the reality is it's very hard to access psychiatry. And truly the preliminary treatment of depression is in our wheelhouse. My big call outs, just to give the call outs at the beginning, is we need to treat depression hard and fast. I mean, there's this term that we coined in an article we wrote in 2016 called early optimized treatment. And we know that depression's neurodegenerative. The faster you treat it, the better you will do. So the days of saying, come back if you don't feel better in a month aren't really a thing, because your best shot is right at the beginning. So they come in, we need to take it seriously. We need to assess them. We need to treat them. And most importantly, which is difficult for primary care because we're all so crazy, is we need to see them again in 2 to 3 weeks. And we need to keep seeing them every 2 to 3 weeks until they get into remission.
Yeah, and I think that, the whole concept of feeling better is obviously important. But if you're feeling better, but you still can't get out of bed, you still can't function at work, you still have conflict with family relationships. I mean, I think there's a whole practicality to cognition, productivity that we need to measure as well, which is part of the frequent follow-up, right?
Right. I mean, you bring up a good point, because the patient will come back and say, hey, doctor, you're the best. I'm feeling better. And that brings back one of my most important points. And CANMAT's been saying this for 15 years. You need to use measurement-based care to objectify your treatment of depression. It's like treating blood pressure or diabetes without measuring a blood pressure, without measuring an A1C. You need to objectify your care. The easiest way to do it is a PHQ-9. It's written in every language in the planet. It'll take the patient less than 3 minutes. It's meant to be taken by the patient, not given by the physician. So a PHQ-9 is done at every single visit until they reach remission. In the original assessment, I'd also advocate for a Sheehan disability scale, and more importantly, so I can give a number to an insurance company if it's needed. I may do a GAD-7 as a surrogate marker for anxiety, and we can talk about the different types of anxiety. And you brought something up you just said, which is so important. I mean, these people can be cognitively impaired from their depression, and there are scales that we can use, like a BCCCI, to measure cognitive difficulties and depression. But as you just said, it's an all-encompassing illness. It causes absenteeism, and more importantly, it causes presenteeism because these people are working and they're just not functional.
Absolutely. And I mean, I think they know it, and there's that whole shame factor, and it just, feeds into the whole depressive cycle. So we'll tag or include those resources and links to the scales. But from like a simple practical perspective, if I see that a patient is booked for mood disorder, depression, anxiety, whatever they verbalize to my staff, that patient is getting, I do the triad of scales. I use the PHQ-9, G87, and then, I usually add some kind of ADHD scale too. I find that that's often missed. And, my staff instruct them that they're to come with their scales filled. They're usually not scored because they're depressed and they can't. Tasks are difficult, and I score them. And then I give them a whole bunch of sheets to take back. And, every time they speak to me or see me, they just can read off their scores to kind of get a sense. So it's actually not that onerous if you have a predefined setup with your staff.
I agree. I mean, I do the same thing. So with us,
Yeah.
I use Ocean for my mental health, and it's emailed to them ahead of the visit. Or if they have a
Mhm.
mental health visit, they're instructed email the office a couple of days before. We'll send you the scales. So when they come in, the scale's in their chart.
Yeah,
I know
yeah.
the number. I need like a diabetic. When they come in, I have their A1C.
Precisely. Mhm.
So I really do want to treat it that way. I need a number, and we're treating to target. The target here is 4. It's a PHQ-9 of 4, not 7. And it's funny
Wow.
because if a patient comes back and says, "Oh my God, I'm feeling so much better. You're the best," and they started at 21, now they're at 8, they feel fantastic. 8's not enough. You have to treat to remission, because if you leave them at 8, the chance of relapse is quite high. So we want to always treat to remission.
I think that's a huge pearl and take-home message for our listeners. So when you talk about measurement-based care, can you give us a sense of, you gave us the scale, a rating of 4 is on the PHQ-9 timeline-wise. Are we expecting changes in 2 weeks, 4 weeks, 6 weeks?
Yeah, it's interesting. So I don't know where this came from, is start low and go slow, because that hasn't been a thing in the depression world for over a decade. So it's not about starting low. It's about starting appropriately and not going slow. So you start on day 0 with whatever antidepressant you choose. We can talk about that in a second. And then at week 2 to 3, you're optimizing the dose of that antidepressant. That means going generally to the monograph-based maximal dose, which is possible with most drugs. There's a few exceptions. I mean, it's hard to get there as fast with sertraline, with venlafaxine, because you're starting lower. So at 2 to 3 weeks, you're optimizing the dose. It's always important to do that. We know that at 1 month, if you've optimized the dose of an antidepressant and you haven't gotten 20 to 25% improvement on a PHQ-9, they will not get remission if it's their first kick at the can. And this has been a change in the recent guidelines. We say you only switch once because there's no evidence for further switches, and you're going to say that sounds crazy. So they're on their second antidepressant and they haven't gotten 20%, and I'm saying don't switch again. Only switch once. The second time you add on quickly, but even the first time, let's assume they've had a partial response. They're on an optimized dose. They've had a partial response. By week 4 to 5, you're thinking about adjunctive therapy. And we addressed that in the guidelines, and we made it quite simple because we demoted most of the first-line adjunctive therapies, and now we only left brexpiprazole or Rexulti, aripiprazole or Abilify. I would argue that 95% of my scripts are brexpiprazole or
Yeah, correct.
Rexulti,
Yeah.
just because, it's a cleaner drug. There's less akathisias. There's less weight gain. It's better tolerated, but aripiprazole is very efficacious. Higher incidence of akathisias. Clinically, they get more weight in, but it's a good option to have for those patients that don't have coverage, the working poor, because aripiprazole generic can be less expensive. But in an ideal world, I'm trying to use a cleaner, effective drug, and that's where I would use brexpiprazole. And those are the only choices you have second line. But let's go back to first line, because we have that list of antidepressants that we've all seen that's 100 miles long, and we're saying choose any first-line antidepressant. And we kind of did that this time, but we decided we needed to dig into the data. And in these guidelines, we looked at over 700 clinical trials, and The data was clear with choices of antidepressants, in this case, that vortioxetine, Trintellix, escitalopram, Cipralex really rose to the top. So all the first-line choices are great, but those two are better based on data. I would argue that I don't tend to use a lot of SSRIs first line just because I'm worried about weight gain. I'm worried about apathy. I'm worried about sexual dysfunction. So in an ideal world, I like to use a multimodal or an SNRI. Multimodal like Trintellix, vortioxetine, Vibrid, Vilazodone, or SNRIs like Effexor, Pristiq, Cymbalta. Those would be my first line choices. Escitalopram's quite effective, as we see in the guidelines, but keep in mind with all SSRIs, weight gain, apathy, sexual dysfunction. Also, they're not the drugs of choice if you have comorbid ADHD, which you talked about at the beginning.
What about comorbid anxiety, which we see?
That's great. It's a great question. So remember, there's two animals of anxiety. There's generalized anxiety disorder, which has been going on for 6 months. They have a worry every day, versus anxious distress, which is 2/3 of our patients with depression. They're anxious. And people always ask, what drug should I use if they have anxious distress? They all have anxious distress, and the guidelines say any first-line antidepressant, any, will suit for anxiety. The other thing to keep in mind is the adjuncts, brexpiprazole and aripiprazole, are very effective for anxiety. So not only will you get a bump in mood with the adjuncts, you get a decrease in the anxiety. So they're effective for mood and anxiety. But I think the key message is, and I know that's what you wanted to hear, is that any first-line antidepressant is suitable for someone with depression and anxiety.
Okay, so we talked about trying optimizing dosage quickly, less than 25% response. You're doing one switch and then adding on. So what about the patient you switched once? They're on optimal dosing for your switched base medication. They're on whatever adjuvant at a maximal dosage. What do we do with those patients that are still not responding?
All right, so they're on optimized therapy. They're on adjunctive therapy. So let's assume I have them on brexpiprazole. They still don't get to remission. So the first thing I'm going to do is what you talked about at the beginning, is I'm going to make sure that I have the right diagnosis. So do they have comorbid ADHD? Am I missing it? Are they actually unipolar, or are they actually bipolar? I mean, bipolar 2s are more commonly missed than bipolar 1s. Is there some substance abuse or an addiction that I don't know about? So I want to rule all those things out if I can. I want to make sure I'll use a rapid mood screener or an MDQ to rule out bipolarity or try and get a sense of bipolarity. I'll do an ASRS, as you mentioned at the beginning, to make sure they don't have ADHD. I'll ask them about habits. Am I missing something? Assume all of that's negative. They don't have comorbid ADHD is the greatest thing to treat because they get better fast with their depression, by the way. But let's assume this patient doesn't. You've done everything right. They're not getting better. They truly are what we call a difficult to treat or a treatment-resistant depression. And those are the ones you need to think about third-line therapy. So a couple of options. I could consider adding bupropion, and that would be probably one of the only circumstances I would add on bupropion. Bupropion should not be used second line. It's a third line drug, as the guidelines would say. I find ketamine's very effective for those that can afford it. S-ketamine or Spravato, I was actually the first physician in Canada to use it with patients right at the beginning of the pandemic. Very effective, but it's expensive and it's not tenable because patients won't continue to pay if they don't have coverage. They have to be in the office for 2 hours. I've been using more IV ketamine. There's a host of IV ketamine clinics in Toronto. I've been using more IV ketamine. I find it's very effective. The group in Edmonton, like Jen Swainson at Tool, have been doing a lot of work with oral ketamine that they give patients to take home. And they're really accumulating a lot more data. And I think I'm getting to the point where I'm going to start feeling more comfortable because I'm seeing their data. So I think it's great. And they've had really good results with ketamine as an add-on.
And just a sense of cost, because I don't think everybody has a sense of how to...
For oral ketamine or intravenous?
Both.
Well, okay, first of all, Spravato, by the time you finish, is about $1,000 a treatment.
Yeah.
You need 8 treatments the first month, $8,000. IV ketamine is $300 to $500 a treatment. The treatments are less frequent, so it's more affordable, certainly. Oral ketamine is pennies to dollars, like really inexpensive. But we have to see in terms of safety, we got to wait for more data. The other thing that's going to be next year are the psychedelics. Like, what are we going to do with them? Like psilocybin, we have 4 trials now with psilocybin, the same dose, 25 milligrams. The only concern I have, and I don't know enough, is that all the trials were done with a psychedelic therapist. I'm not even sure what a psychedelic therapist is and where we're going to find a lot of them. So the trials were done with the psilocybin and the psychedelic therapist, which makes sense to have the therapy during the treatment. But I don't know how that's going to pan out. Like, are we going to get data that shows the drugs work without a therapist? I think those trials are being done.
Yeah.
But I don't know that answer. And I don't know how much it's going to cost.
Yeah, I mean, it's generally too about the access and the supportive care, not just the dollars and cents.
Right. No, for sure. It's still going to be in a clinic. You're going to have to spend a couple hours. You can't drive. These are all things we need to think about with that therapy. But I think the majority of your patients, the majority won't have treatment resistance, and you can treat them adequately with first-line adjunctive therapy, etc. Remember, adjunctive therapy is more the norm, like in hypertension and diabetes, where you're using more than one drug.
Course.
I mean, almost half of your patients will need more than one drug.
Yeah, and I think we have to destigmatize. It's still, patients come in, they're depressed. The first question they ask, which will lead into my next question, is, Doc, when can I come off these medications? Am I on long term? So what are the guidelines in setting expectations for patients?
I mean, if it's their first episode of depression, we say treat them for 6 to 9, I say 9 to 12 months after remission, not from when you started. If it's their second episode, recurrence rates are really, really high, and I try and convince them to stay long-term. Certainly, if it's a third long-term, the risk of relapse, if you've had 2, is exceedingly high, and I really try and keep the long-term. The other things that we'd be remiss if we didn't talk about, and I know, Christine, we talk about a lot, is the non-drug therapies. I mean, CBT has been shown to be very effective. Lots of ways to get it. It's not always achievable due to cost. There are ways to get it for free. I mean, in Ontario, we have Big White Wall, we have Bounce Back. My favorite depression CBT site is Mood Gym.
Yeah, absolutely.
Mood Gym is a large Australian website that has lots of data. It used to be free. I think it's $20 or $25 now. I mean, I think the biggest problem with Mood Gym is adherence rates are quite low, but it's very, very effective. And the other thing that we need to talk about, and it's exceedingly effective, is exercise.
Absolutely. What did they say? Motion is lotion, right?
Right. And and we even say in the guidelines, and if you have a mild depression, which means a PHQ-9 between 5 and 10, and the patient's willing to have CBT and exercise, you can get them to remission. You don't need to use drugs. And we actually say that in the guidelines. We determine treatment based on mild, moderate, or severe. If they're a mild depression and you can convince them to have therapy and exercise, you don't need drugs. But we say CBT exercise, psychotherapy, exercise, or drugs, or drugs, because not all people are willing to exercise and have psychotherapy.
So for guidance, people are going to ask, what type of exercise, how long, how frequent?
The depression guidelines are quite lax compared to other guidelines. They say 90 minutes, but every other guideline says 150. So I say 150. The easiest way to get it by far is I'm a huge advocate for steps. I always say 10,000 steps, but that's a made-up number, by the way, that the Japanese made up years ago with no data. We now have data, really good data, that you're starting to get benefit with as little as 4,000 a day, and you tend to top up at about 7,000, so 50,000 steps a week. So I've gotten a little bit more generous. I'm saying 50,000 steps a week. I don't care how you get it, but get your 50,000. And I will be so crass to ask my patients to see their phone. And they'll show me, and I'll look at their phone, and they're averaging 1,000 a day.
Yeah. It's amazing how those pedometers can actually be a therapeutic tool. You don't have to get a fancy Apple Watch, spend $15 on Amazon.
Absolutely. Your every phone can track
Yeah.
steps. And then they'll say, oh, but I don't carry it in my pocket all the time. Sure. But you should carry in your pocket because I need you to get 50,000 of them.
And I think there's also emerging evidence, just to close the exercise discussion, that exercising outside, getting fresh air, if possible, is an added therapeutic benefit. And weightlifting, too, especially for women in sort of midlife, has definitely anxiolytic properties and overall, works as an antidepressant. So go back to basics.
I agree.
Eat real food, sleep. We did a talk on sleep a while ago, and exercise. I think a lot of the stuff we forget is this simple.
And I mean, it's funny because I heard a podcast a couple days ago about the benefits of early morning sunlight.
Mm-hmm.
Like, and this guy's was an advocate of, and he was talking about the biochemical basis of staring at the sun in the early morning when it won't damage your eye and won't damage your skin while the sun is still low, and the benefit of looking at the sun for a minute to get those rays and the changes. It's funny. I mean, I can't verify it scientifically, but he was quite compelling on the benefits of early morning sunlight, even if it's cloudy. It was quite amazing.
And we, in Canada, you have to have an exercise plan or a routine plan that corresponds to seasons. Mujib's from Australia, they get sunlight most of the year.
Right.
We're a little bit different here. So, I mean, that's the reality. So you bundle up and go outside and get some fresh air.
I agree.
And just, on the topic of other options, I know that we should spend a moment talking about ECT or TMS.
So effective. I mean, I didn't talk about it, and I should have actually. Thank you. ECT is so effective for TRDs. It's a hard sell with our patients, but it's really, really effective. And we've all had a handful of patients that have done it and the tremendous benefits. Yes, there are side effects. First of all, it's tough because it's a lot of treatment, a lot of generals to have. And yes, you can have short-term memory issues. It's extremely effective. And actually, I'm sorry that I didn't mention that first in terms of TRDs because it's so effective. But it's funny that even and I'm very comfortable in this world, don't jump to ECT. I'm thinking more of medicinal therapies. And thank you for bringing it up. It's a great point.
Well, it's accessible, right? So for a lot of the medicinal therapies, access, and you mentioned finances are a problem. And I find that, at least in Toronto, some of the clinics really do have systems in place. You just, it's time and it's
a hard sell. I find it to be a very hard sell.
Yeah, I haven't had many patients go through it, but the patients who did, they had positive responses.
Right.
See, you know what? I said you were a big wig. You're a big wig.
No, not a big wig. But I find treating depression one of the most gratifying things in practice because these patients are so thankful you give them their life back. And we have to really explain to our patients this is a physical illness like diabetes or hypertension. It's not your fault. You're not doing anything wrong. You're not crazy. It's a physical brain illness that we can successfully treat. And we've come a long way. So I'd encourage our non-physician listeners or our physician listeners, please see their physicians if they suffering from a major depressive disorder. I mean, also a lot of resources like Mood Disorder Society of Canada is great. I just published an article for them, or I edited an article for them. It's a really nice review article.
So I think we'll include those in the links in addition to the scales. Okay, Dr. Bigwig, 3 take-home points.
Very, very common. Don't miss it and treat it hard and fast. Measurement-based care, measurement-based care, measurement-based care, and add on quickly.
And I think maybe next year we'll be back talking more about the ketamine options and
psilocybin.
Psychedelics.
Yeah, I think it's very exciting.
It's a brave new world out there.
Nice to see you, Christine. Thank you.
Nice to see you. Speak soon.
Bye.